Okay, so the clinic that I work at, oops, sorry, as I figure this out myself, is EYEgility. When I was in school, I did some sports vision training with the Indiana University football team. That is how I got interested in sports. The training was very basic, but here in the last 5 years or so, the training and the technology has really improved. The training of sports and athletes has led me to also work with concussion patients. Obviously, concussion is brain injury, brain trauma, and that has launched me into the neurocognitive, working with people who have neurodegenerative disorders, stroke patients, things of that nature. Parkinson's falls in the neurodegenerative aspect. I'm going to go over some different things that I use in my clinic to help those patients. Some of them are fairly basic and straightforward. Some of them are a little more complex. So again, the main highlights we'll be talking about is new detection of Parkinson's disease with right eye technology, the ocular and visual side effects of Parkinson's disease, ocular and visual side effects of the treatment of Parkinson's disease, and new and current treatment options for patients. Just so everyone's on the same page, Parkinson's disease is a progressive nervous system disorder that affects movement. Symptoms usually start gradually, sometimes starting with a barely noticeable tremor in just one hand. Tremors are common, but the disorder can also cause stiffness and slowing of movement. Dr. James Parkinson reported an essay with 6 cases. This is the resting tremor, abnormal posture and gait, paralysis and diminished muscle strength, and how the disease does progress over time. The cause of Parkinson's disease is unknown. It is believed to be both genetic and environmental factors that contribute to it. There is currently no cure for Parkinson's disease. Treatment aims to help improve the symptoms. Like I said, the Journal of Neurology, and neurology.org is their website, just this past week followed a group of doctors. They were actual physicians in Great Britain, and the study showed that there was a significant decrease in Parkinson's-related deaths the longer they had been smoking. I am not encouraging anyone to go out and start smoking. I just found this very interesting. And the longer they smoked, the lower the rate of Parkinson's-related deaths. So it's good to know there's something out there. The key is, what can it be to help treat patients without causing any undue harm? So early in the disease, the most obvious symptoms are shaking, rigidity, slowness of movement, and difficulty with walking. What has been known for a long time is that the eyes, with their very fine, delicate movements, may be a way to get early detection of Parkinson's disease. A study about 10 years ago, maybe 12 now, found that a instability of ocular gaze movements in Parkinson's patients. 2 of the 60 control subjects had the same issue. And after follow-up of about 5 years, 1 of those patients developed Parkinson-like issues. The technology was not there to get into clinics at that time. Technology, as we go forward, gets less expensive and more portable and easier to access. Right eye technology is that technology that now allows us to track, monitor, and follow those eye gazes, those fixation, which is focusing issues that are beyond what we can even see with our naked eye. And right eye, just this past December, was FDA approved for testing Parkinson's disease, for finding early cases with their technology that allows them to be early diagnosed versus going through a lot of different tests. Sometimes it does take quite a few tests to be diagnosed with Parkinson's. This allows us to more rapidly and readily diagnose patients. So with the right eye, no single test is capable of definitively diagnosing Parkinson's disease. There's a variety of neurological examinations, not only just eye from a neuro ophthalmologist or a neuro optometrist exam, but other aspects for the clinical diagnosis. And misdiagnosis is still relatively common, even though things have progressed. This is a letter from George Gitchell, a PhD researcher at the Parkinson's Disease Research and Education Center at the Richmond Veterans Affairs, that 60% of patients are misdiagnosed at least once, with up to 3 of those misdiagnosed twice. And that is unacceptable, and it's terrifying in this day and age. With all our modern medicine and technology, the sooner, again, we can get to patients and get them treatment and get them help, the better their quality of life will be long term. Right eye does, I think, and will continue to play a huge role in helping these patients be diagnosed early, early treatment, early management, and improved quality of life. So we are fortunate that we are the first and only clinic in Nebraska, all of Nebraska and Western Iowa, to have this right eye technology. I have embedded a video here. Hopefully this will pull up, and I will show you a quick video here, a couple minutes, about what right eye does. Maybe. All right, I hope you're all able to see that. So this is the printout we get from the right eye. It gives an individual score. The score is based on a normative database from people's age group. So there is a functional vision area, and then the individual score, and then how they rate on that scale. It gives us different information on how different eye tests, how patients perform. Pursuits are pursuing an object or tracking across a page. So if you think of reading, following along a line on a page is pursuing that line, following a train moving on tracks is moving across. That can be vertical, it can be horizontal. Saccades are rapid eye movements. If you're going from the end of a line on a page to the next one, moving across, up, down, they're fast eye movements. Fixations is just holding steady. You can see here there's different ways they track. One is the circular tracking here in the middle left, okay? That should be nice and smooth. You can see that this individual, the movements are not smooth. They're jaggedy, there's irregularity. Again, this can be from a number of different things. It can be Parkinson's related. It also can happen with concussions or traumatic brain injuries, stroke patients, things of that nature. There's also horizontal speed it measures here, how quickly the eyes can move and then hold their gaze stability. This again here is just a stability of just holding one spot and not moving. There's also horizontal tracking, vertical tracking, and then the right eye technology allows us to see, hey, what nerves or what part of even the brain is being impacted here? Where would this problem originate? If it is a horizontal, vertical, where does that impact the brain? Then also the eye muscles. Are there any of the 6 muscles per eye that help move the eyes, help stabilize them, help keep them focused and not separate to cause double vision, things of that nature? It helps us locate those. So this testing used to be done with just following a finger. A doctor would move his finger across or have you look from one finger to the next. The right eye uses infrared lights and technology to allow us to track that. And again, it can track and see even better than we can with the naked human eye. Allows us with an economical device to bring it in versus just having to go to a major research center. It's a very quick test, does not take long, a few tests, and then it also allows us to prescribe treatment. There's several different types of treatment we'll talk about for patients. Not only just visual acuity is what a lot of people think, go to the eye doctor, look at a chart, I can read it. Well, that's not the real world, and especially in this day and age with the amount of computer use, that is not really the type of vision we use anymore. So the type of conditions that relate to the eye with Parkinson's, number 1 is an incomplete or delayed blink, lag ophthalmos or incomplete closing of the eyes, reduction in tear secretion or tear production. We already talked about with the right eye, poor eye tracking from abnormal saccades, which are quick eye movements, pursuits, which are tracking eye movements, extraocular movements are the 6 muscles that help align the eyes and move the eyes, and functional vision issues. Functional vision, again, if you're looking at a computer, you're going left to right, you're going up and down, you're looking at different pictures. You're not just sitting in a chair looking at some letters on a chart in front of you that are black on white. Parkinson's can also limit upgaze. It can lead to convergence insufficiency, and this is a big issue for Parkinson's disease patients. Convergence insufficiency is the inability or the difficulty of bringing the eyes together up close. When there's a lot of reading, convergence insufficiency really is detrimental, can cause double vision, can cause poor reading ability, and it can lead to the lack of desire to read just because the eyes are tired, the eyes are fatigued, they do not want to work hard, and it's a lot of effort. Another interesting thing that can happen with Parkinson's disease is that visual hallucinations are quite common in patients with Parkinson's disease. I mention that because sometimes people are always concerned or scared. I'm seeing something, I'm having a hallucination. What does that mean? It is something that's very common in Parkinson's. And if you notice it, and if you're aware of it, again, feel free to speak to your provider about that, because we want to always know what you're experiencing, what is going on with your eyes, and what we can do to help manage that. Like I said before, you go to the eye doctor and you can sit in a chair and there's a target there, it's not moving, it's black on white, you blink a few times, you work at it, and you can get 20/20. That chart, the Snellen eye chart, it was developed around the time of the Civil War. That only measures the central 6% of your retina, the 6% of the tissue. The retina is the tissue inside the eye that allows us to see. So up to 94% of our vision isn't even measured with the eye chart. 80% of our senses come through the eyes. And so if you think that of that 80%, only 6% is measured on that eye chart, there's a whole lot of our sensory abilities that are not truly being measured with a regular eye chart. And that was the aspect that really interested me with the right eye, is how can I help and how can I work with patients beyond just, hey, great, you can see 20/20, go from there. No, doctor, I can see 20/20, but I'm still having problems. I can't read. What is going on? Well, you see 20/20. Why can't you read? It's that functional vision. It's that other 94% of the tissue. How is that working? How are the eyes working together? So again, we already talked a little bit about this, about the eye movements specifically impacted by Parkinson's disease. Again, pursuits, which allow the eyes to travel together to follow a moving target. Saccades, again, the rapid eye movements that allow the eyes to quickly jump and move to a new target. And then the vergence eye movements, both convergence and divergence. Convergence is usually what happens when we look up close. Divergence is when we look at distance. So our eyes converge or come together when reading, holding that. And again, a lot of Parkinson's patients have a difficult time with those convergence movements. Their muscle system has a hard time moving those eyes in And then after they're moved in, holding them stable where they can function to read, where they can use their visual system to make those movements of pursuits and saccades and hold them steady to get one image and not developing double vision or diplopia. So how do we treat some of these Parkinson's disease issues with the eyes? Well, first of all, even though I don't think that all of our vision, and like I said, it's only 6% of the retina, is what we see on the chart, an updated glasses refraction, just making sure that you are seeing the best you possibly can. That's a common cause of vision issues for people with Parkinson's disease. Very simple, get a new prescription, update the glasses. That can make a big difference for a lot of people. There's a lot of people that come in, and because our brains don't like to do any extra work, if one eye is blurry, they come in, they don't even know they have one eye that's extremely blurry until we cover the good eye. All of a sudden, they notice, whoa, hey, what's going on here? What has happened? Why is that vision blurry? Is there something going on other than just the Parkinson's that would be contributing? And is it something as simple as a new pair of glasses could help improve? Another common issue is the dry eye issues that we talked about earlier that can happen with Parkinson's disease. There are some newer things out there for that treatment. Again, sometimes it's something as simple as artificial tears and lubricants. Sometimes it's something called punctal plugs, cyclosporine or lifidographs. And we'll talk a little bit more about these in just a bit, autologous serum and amniotic membranes. The treatment of eye disorders, the eye movement disorders, the functional vision therapy, and or glasses with Prism. Functional vision therapy is, again, working with the visual system and leading to the brain. Again, 80% of our sensory system comes through the eyes. A large percentage of the brain is used and is working with the visual system. Some people say it's 80, 90. Some people even say up to 100% of our brain is involved with vision. That's a high percentage. And when you have a neurodegenerative disorder like Parkinson's, anything we can do to maximize that is really key to a better quality of life. The functional vision therapy, sometimes it's something as simple as some eye exercises to help treat and manage those symptoms of the eye movement problems. The right eye does allow me to do home-based treatment where you can click on your computer, your monitor will show an image and just work with you and to do some certain eye tracking movements, positional movements, gaze movements, things of that nature, kind of like you saw in the video. And again, the functional vision therapy is trying to activate areas of the brain impacted by Parkinson's disease, specifically the basal ganglia. You can track and you can target certain areas of the brain with eye movements and eye tests, whether it's the frontal lobe, the temporal lobe, parietal lobe, all those areas of the brain can be targeted with specific eye movements and eye disorders. But even though we can do that, the patient has to be involved. The patient has to want to be proactive in doing these exercises. The goal, again, is to maximize the vision and neurocognitive abilities patients have. Again, cannot cure the disease. We just want to make the quality of life the best that we possibly can. And usually that sooner we get that treatment, the sooner the diagnosis happens. Like, again, I said the right eye can help get that earlier diagnosis, the sooner we can help manage and control any issues that can arise from Parkinson's disease. Another aspect is Prism glasses. So prisms bend light in the direction needed to correct eye movement disorders. So if your eyes can't converge, and we do some testing and they still are struggling to converge, we can give Prism glasses that instead of light going straight through the lenses, diverges them out farther, so the eyes don't have to go in as far. This can happen again with traumatic brain injuries, other aspects, but this is pretty common. I'm using these for my patients. Some patients have a balance issue where they feel like they're tilting to the right. I can actually use Prism to help them feel like they're straight up and down. They're tilting the left, but they feel they're more straight. They're more aligned with what they perceive with their brain. They are often used for specifically reading with a convergence insufficiency, so a lot of these patients do need two pairs. Blinking abnormalities, again, is less frequent with Parkinson's disease. Sometimes Botox or botulinum toxin is used for the muscles around the eyes to help with the blinking, help with those movements. Blepharitis is a common issue that I see with Parkinson's patients. It is an inflammation, irritation of the eyelids, often associated with an overgrowth of bacterial cells that leave a mattering or granulation on those eyelids. Usually a warm washcloth will often take care of it. Sometimes a medicated eyelid wash or an antibiotic ointment in very severe cases will be need to manage that. Sometimes it's a short-term treatment. Sometimes it's a longer-term treatment. They really, bad cases, they really do make the patient with treatment feel much better. They can actually see better and improve their visual clarity. Sensory deficits. So dopamine neurons in the retina can be lost with Parkinson's disease. This can lead to contrast sensitivity, color vision issues. Usually the blue-yellow spectrum is the one versus the red-green that's most impacted. We can put tints in lenses for glasses patients that need them to help with that contrast sensitivity, to help with that clarity and distinguish those colors if they're starting to be impacted by Parkinson's. Neuro Optometry treatment. This is an area, like I said, different than neuro ophthalmology. All right. Neuro optometric therapy is a process of rehabilitation of visual, perceptual, and motor disorders. These are involved with neurodegenerative diseases, but also concussion patients, patients who've had stroke, issues of that nature, can help with strabismus, or is one eye turning in or out or up or down, double vision, the eyes not working well together, or binocular dysfunction, convergence issues we talked about. Also accommodation, again, the muscle system inside the eyes that allow us to go from distance to up close can sometimes be impacted. Ocular motor muscles, again, if one of those muscles like I showed on the right eye test is not working properly, what can we do to help manage that? The visual spatial dysfunction, where are you at in space? A lot of patients, when they have a neurodegenerative defect, they are not aware of where they're at in space. Sometimes you actually have to touch the patient to help them feel grounded when their visual system is off. Again, prisms can help with that. If their system is off, where they feel like they're not aligned or their brain fields are not aligned, sometimes you have to realign them through their eyes with those prism glasses. Their perception, what they perceive, and then cognitive deficits, traumatic visual loss with any type of head trauma. Again, eye exercises, lenses, prisms, neurocognitive training, which is, again, a lot of that is those eye exercises. Some of that through the right eye, the home training, can help maximize the brain's ability. Like I already said, 80% of our sensory input comes through our eyes. That's a huge number. And anything we can do to improve that can have a huge impact on the quality of people's lives, especially when we can target the specific areas of the brain that we can find are weak. What can we do to maximize those areas to give the improved quality of life? Some of the issues that can develop with Parkinson's disease also can come from their medications. Levodopa, which is a very common one, that can also cause eye movement disorders that instead of being too slow, it causes the eye movement to be too fast, too erratic, and this can also lead to reading and concentration problems. Safanamide is double vision and blurred vision, and dopamine agonists, especially amantadine, can cause some dizziness issues. Any medication can have a side effect. Just because a medication isn't listed as a common cause of an eye issue, or an eye issue isn't listed as a common relation to a medication, does not mean either one of those can't happen. Any medication can impact any part of the body. And sometimes not one medication, but a medication in combination with another can cause an issue. Another big issue with Parkinson's disease is dry eyes. And again, this is a fairly common problem, but it is very detrimental to our visual quality, visual acuity. When there are not enough tears, I compare dry eyes to kind of like having a dirty windshield. If you can't see through that windshield, it causes you a whole bunch of problems, and we can do all we want. We got to get that windshield cleaned up. Artificial tears are lubricants that can help moisturize the eyes. Most of these are over the counter. There are different qualities and quantities that you can buy. If you're using them frequently, the preservative-free is definitely what I recommend, because if your eyes are already dry and irritated, any preservative can make them more irritated. Punctal plugs. This is a common thing I do. The punctals are in the lower and upper lids. They're just the natural area of the tears to drain off of the eyes so they don't spill over. We can put plugs in these, and if you think of a stopper on the bottom of the sink, you pull the stopper down, the moisture that is in the sink builds up and up. Well, same thing with a punctal plug. You put the plug in there and the moisture on your eyes stays on there longer. This is painless, very straightforward. You can do it in the exam chair. A lot of people are a little hesitant because it seems kind of intense. It's on the lid, it's not on the eye itself, but it's very straightforward, and I do this frequently because a lot of patients do have other issues that may make it difficult for them to get artificial tears or lubricants in the eye. This just makes it easier for them to keep moisture on their eyes. Cyclosporine and lifitegrast, these are prescription medications designed to help make tears more efficiently on the eyes. They help with a lot of the inflammation that can happen with dry eyes, other disease process, and then allows the eyes to heal, produce tears more efficiently. These are usually covered by insurance. Autologous serum is another one. These are last two are autologous serum and amniotic membranes are for the more severe dry eyes. Autologous serum drops are drops that are manufactured out of a patient's own blood. They have a blood draw. The blood is spun. Growth factors, specifically epithelium promoting growth factors, are spun out, and these are then put into liquid form in lubricant in vials and given to the patient, and then they use these themselves. So again, you're using your own body to heal itself, which is great. Negative is it can be really expensive, not covered by insurance. Amniotic membranes, these are membranes that are put over the top of the front surface of the eye like a contact lens. They're larger, but the tissue allows the eye to heal and replace damaged areas. They are anti-inflammatory, they're anti-scarring. They can contain growth factors that can help with any wound healing on the surface of the eye. Again, these tend to be a lot more expensive. Amniotic membranes tend to be covered by insurance, but they can be very expensive, and they're not always the best option based on that, but it is nice to know there is an option. Another company I work with other than right eye is called Synaptic. They do a lot of different things for eyes and healing. They have different glasses that can be used. I'll show you a video here in just a bit, but they can also help with eye-hand coordination to work with movements, work with those neurocognitive training abilities to help patients have a better quality of life. I'll see if I can open this up here. And this is one of the pairs of glasses. They have glasses that flash, strobe glasses here. You wear them and they flash. Again, it blocks out part of the visual system, allowing the brain to work harder, and then the brain does not have to work as hard as when they're removed. And then I will show the other one. Oops, excuse me. And this shows another test that Synaptic has. It's a big light board. Patients then work on different visual tasks, whether it's pursuits, saccades, reaction time, eye-hand coordination. It allows them to practice these different movements to help improve their function neurocognitively. If we can get this here, I apologize for the delay. And improve their ability to function in the real world. You know, a lot of this stuff is translating into the real world, not just, hey, you're sitting in a chair, you can do it, but how does it relate to what you can do in the real world? Again, trying to improve quality of life. And that's really what it's about, is improving a patient's quality of life. Let's try. I have one more. I'll try this one more time, and then I have one more video I wanted to show you regarding the synaptic strobes. Well, that's not coming up. I apologize. I'm going to go here. And this is a patient who has had a neurodegenerative impact in their life. I honestly do not know if it is Parkinson's, if they had a concussion, stroke, or something like that, but it shows what can happen. Again, I'm not going to say that this is what we do with all patients, but it just shows some of the things that we can do technology-wise to help improve patients' quality of life, and that is always the goal, is what I said earlier. Let me go ahead and pull this up. So this patient has the synaptic strobes on, as you can see, and they're working on an irregular platform there. That platform he's working on is an irregular platform to work on balance, gait, and movements in not just a typical environment. He's going to take off these synaptic strobes. You can see he has a belt because of balance, something to grab on if he stumbles. And he's going to show off here a little bit. All right, so that's pretty much the end of the talk there, I see. I will open it up for any questions you might have.